Okay, so now we are coming to the final part of this edition of how to interpret the RCT and how to translate it into clinical care. So, finally, using the numbers which are provided in that article in the original case scenario, patients in the Ramiprin group walked 75 seconds longer than without pain in the placebo group and 255 seconds longer overall. So the effect of Ramipral is convincing, giving that the 95% confidence interval for the Ramipral group was lower, 60 to 89 seconds, but in the placebo group, it was 215 to 295 seconds. That is, the narrower confidence interval was found in the Ramipral group, and the lower boundaries are far, showing that no effect, right? That is 0 seconds. The clinical importance of walking 75 seconds without pain is likely noticeable, given that they could walk a mean of 140 seconds without pain at baseline. This finding is consistent with a substantial improvement in a secondary outcome. This is a measure of health related quality of life for patients in the Ramipil group. Okay, so finally, the third coming to the third division. So, how to apply these results to patient care? So, now how to apply these results to the patient care? So, where the study patients similar to the patient in your practice, whether the patient you have encountered is similar to the study patient. If the patient before you would have qualified for enrollment in the study, you can apply the results with considerable confidence or consider the results generalizable. Often, your patient has different attributes or characteristics from those enrolled in the trial and would not have met the study eligibility criteria. Patients may be younger or older, or may be sicker or less sick, or may have comorbid disease that would have excluded them from participation in the study. The study probably the result of the study applies even if, for example, adult patients are 2 years too old for enrollment in the study, had more severe disease, had previously been treated with a competing therapy, or had a comorbid condition. A better approach than rigidly applying the study inclusion exclusion criteria is just ask whether there is some compelling reason why the results should not apply to the patient. You usually will not find a compelling reason, in which case you can generalize the results to your patient with confidence. A related issue has to do with the extent to which we can generalize findings. The issue of drug class effects and how conservative one should be in assuming class effects remains controversial. So the thing is how much expertise is needed in procedural interventions. So unlike pharmacological interventions in which we expect the intervention to vary minimally between patients, procedural interventions may substantially differ based on the expertise of the physicians and the technology available to deliver the intervention. So that is some difficulty which we will encounter. So, for example, if it is suggested that the off-pump coronary artery bypass surgery reduces the risk of post-op complications compared to the traditional on-pump techniques. So there is some difference between off-pump and on-pump technique, which you can refer. So, when the two techniques are compared in a randomized trial, one must be careful interpreting the results because there is a potential difference in expertise. For example, if surgeons participating in the trial are on average less skilled with the off-pump technique than the on-pump technique, then the outcomes of patients in the off-pump technique may reflect the surgeon's inadequacy or inexpertise or inexperience there rather than the true risk and the merits of the technique. Further, surgeons may choose to switch off from off-pump to on-pump technique more frequently than they would switch from on-pump to off-pump technique. This bias will affect the demonstration of showing that there is no difference between these techniques. One way of preventing these techniques misleading bias is to ensure only surgeons with sufficient expertise in both on-pump and off-pump technique are allowed to participate in the trial. This was done in the coronary trial or CABG on-off pump REVAS study. You can see the coronary trial. So this trial was published. You can see how it was done, the methodology of the trial. Another method to prevent this differential bias expertise bias is to randomize patients to a surgeon with expertise in one technique or a surgeon with expertise in the alternative technique rather than randomize the patient to a surgeon who will perform either procedure to which the patient is randomized. The final issue arises when the patient fits the features of a subgroup of a patients in the trial report. We encourage you to be skeptical of subgroup analysis. The treatment is likely to benefit the subgroup more or less than the other patients only if the difference in the effects of the treatment in the subgroups is large and it is unlikely to occur by chance. So So finally, after you see all this, keep all this in mind. Then also, then you ask the another question whether the all the patients' important outcomes are considered or not. So treatments are indicated when they are important, provide important benefits. Yes. So, for example, demonstrating that the bronchodilator produces small increments in forced expiratory volume patients with chronic airflow limitation, that a vasodilator improves cardiac output in heart failure patients, or that a lipid or that a lipid lowering agent provides cardiac or improves lipid profile, does not provide sufficient justification for administration of these drugs. In these instances, investigators have chosen substitute outcomes or surrogate outcomes rather than those that patients would consider important. So, trials of the impact of antiarrhythmic drugs after myocardial infarction illustrated the danger of using substitute outcomes or endpoints, because abnormal ventricular depolarizations are usually associated with high risk of death, and antiarrhythmic drugs demonstrated a risk reduction in both abnormal ventricular depolarization. So the substitute endpoint made sense that they reduced the risk, right? But it didn't provide so, because clinicians who rely on the substitute endpoint of arrhythmia suppression would have continued to administer the three drugs, and the considerable detriment of these drugs would have happened because they found higher mortality in these patients who had continued on these drugs. So the end point should not be a substituted endpoint, and there are some endpoints like a composite endpoints, that is we can also usually we come across a large trials published by NEJM that they show that the composite endpoint of death, non-fatal MI, and admission for an acute or coronary syndrome, uh, which demonstrated intent towards increasing mortality with the experimental therapy and convincing effects only on admission for an acute coronary syndrome. So this composite outcome would most strongly reflect the treatment effect or the most common of the components, which is the admission of the acute coronary syndrome, even though there is no convincing evidence that the treatment reduces the risk of MI. So then we see if finally, we after seeing all these points, now coming to the final how to translate this clinically. So this will be continued in the next video. Thank you.